leadership throughout this past year. Sheila, please go ahead.
Thank you very much, Kathy. After seeing the devastating impacts of the COVID pandemic on long-term care residents and workers in this last year, CFUW members organized to adopt 2 national resolutions on long-term care. These resolutions aim to protect the most vulnerable in our communities by urging the provincial, territorial, and federal governments to work together to establish common evidence-based standards that ensure all Canadians can live in safety, comfort, and dignity and have access to high-quality, affordable long-term care, and urging the creation of universal, accessible, regulated, respectful, and quality long-term care for the growing needs of elderly persons by placing long-term care under the Canada Health Act. To kick off our national campaign for long-term care and elder rights justice, we are joined by panelists tonight, distinguished panelists, who will share their unique perspectives on the current state of long-term care in Canada and the ways in which we can move forward as citizens working for dignity and justice. We are also joined tonight by Maria Campbell, Policy Advisor to the Minister of Seniors, Deb Schultz, who is observing tonight's discussion and will provide the Minister with a summary of what she's heard. So I'd like to introduce all of the panelists all at once, and then it will just flow smoothly from one to another. Our first panelist is Dr. Pat Armstrong. Dr. Armstrong is a distinguished research professor of sociology at York University in Toronto. He held a CIHR chair in health services and nursing research and has published work on a wide variety of issues related to long-term care, healthcare policy, and women's health. We thank you for joining us, Pat. The next, we would like to welcome Dr. Phyllis Hymmen. Phyllis is the former president of Concerned Friends of Ontario Citizens and Care Facilities and was part of the steering committee for Ontario's first long-term care task force. She is a member of the University Women's Club North York Long-Term Care Working Group. We welcome and thank you, Phyllis. Our next panelist may or may not be with us right now. I will introduce him just in case. He is Bill Vandergorder. Bill is the Chief Policy Officer for CARP, Canada's largest advocacy association for older Canadians. He was the founding chair of CARP's Nova Scotia chapter. Bill is a longtime seniors advocate, policy developer, and media commentator. We hope that he will be with us tonight. Next, I'd like to introduce Mary Connell. Mary is the project manager for the Butterfly Model project for the region of Peel. Mary is a dementia advisor and a person-centered care advocate. Welcome, Mary, and thank you for joining us. Our final panelist is Karen Henderson. Karen is the founder of the Long-Term Care Planning Network. The Long-Term Care Planning Network is Canada's leading on and offline resource center for aging and long-term care. Karen has a long history in the needs of aging Canadians, having been in dementia care for 14 years prior to the creation of the LTCPN. Karen, we welcome you and thank you for being here. So Pat, go ahead whenever you're ready.
Thank you very much, and thank all of you for being here and for caring about long-term care. I've been the lead on a 10-year project that looked at long-term care in 6 different countries: Norway, Sweden, Germany, the UK, the US, and Canada. And we were looking for promising practices to try and make long-term care as good as it could be, but also a positive option for rather than the last and worst choice of everyone. And we wanted to take context into account when we talk about promising practices, because we don't think that there's a single right way, although we certainly agree with you that there are standards that we can establish that can be the basis for figuring out how to make that care as good as it can be. So we're talking about standards and not about standardization. So what I wanted to do to start the discussion tonight is first of all talk about some of the basic assumptions we started with and we think are important to start with. The first one is that care is a relationship, and that relationship involves all those who live in, work in, and visit in long-term care. We also think it's a women's issue. We have to take gender into account. The overwhelming majority of those in long-term care in all 6 countries are women, and so are those who provide the care, many of them racialized and are newcomers to the country. And of course, we also have to take other identities into account. That care and decent work are human rights and our shared responsibility is another basic assumption we start with. And fundamental to our projects has been the notion that the conditions of work are the conditions of care, and that we need to have that recognition as fundamental to our standard setting. And finally, that all services are part of long-term care, and I'll come back to that in a minute. When I set out basically 6 areas that we need standards for. So the first one, and it's obvious to everyone, is the staffing numbers. The numbers matter, but so do the conditions, not just in terms of attracting and keeping staff, because these are areas of very high turnover. People leave because of the conditions. But also the conditions are what make good care possible. And that goes beyond pay and benefits to full-time jobs, to continuity in terms of care, full-time work, regular permanent job, part-time jobs, and to making teams possible. It also means continuous education and some autonomy for staff in terms of how they work and how they respond to the individual needs. If you don't give them the power to do that, they can't respond to individual needs. And that applies to all employees. So my second area is physical environments. And here we're not just talking about the room sizes that have been so central to much of the discussion that's been going on under COVID, but also attention to things like laundry and clothes. We wrote a book called Wash, Wear, and Care because everywhere we went, we heard about the importance of clothes and laundry. And we also heard continuously about the importance of food and of housekeeping and cleaning that are central to care, not just to the notion of infection. We also, in terms of physical environment, heard a lot about where homes are located and about how we deal with death and what kinds of spaces we have for staff and space for the community outside to come in to the long-term care, as well as, of course, for the people in long-term care to get to the community outside. We heard a lot of discussion about home-like, but we also heard a lot of debate about what does home-like look like? Whose home are we talking about? Because even within our group of 27 faculty members in this project, we had very different ideas of what home looks like. So my third area is access. And access is partly to do with how many you have, how many beds or how many rooms, how many facilities you have and where they're located. But it also has to do with the information we have on them, information about how do you get there, what happens when you're in there, what kinds of rights do you have when you're there, that it's information on the physical and the social activities that go on. Access is much larger than financial, although financial, of course, is important too. Next is the area of accountability and decision-making. What counts and who is included in the decision-making is really important. We've done a lot of our accountability in terms of counting what can be counted and spending a long time doing that counting. And we think that there are better ways for us to make sure that the places people live in, work in, and visit in respond to their needs. And finally, we need to balance safety and risk. And in fact, there are a number of areas where we identify tensions and talk about how they need to be balanced rather than figuring out how we could go in, for instance, the direction of prioritizing clinical care over social care. But safety and risk has become particularly obvious during COVID as we barred family members from entering long-term care. And we have what I should say, shouldn't say we, but because it's something in our project, and I'm sure everybody in this room knew, how important those social contacts are to the people who live in long-term care. It's also become more visible how important they are to getting basic care, given the kinds of staffing levels we've had. But we have to be able to balance safety and risk, whether that means access to the outdoors or access to your families. And life without risk can be boring. So we have to think about ways that we can balance those things so that you can get outside and be in the garden, go for a walk, do a number of things that make life worthwhile living. So I would argue that national standards have to begin by looking at these 6 areas based on the kinds of assumptions I introduced at the beginning. And I look forward to hearing what others on this panel have to say and what you who are listening and watching have to say. Thank you.
Hello, everyone. One of the things that I'm so aware of around long-term care is that it's something that we absolutely dread for ourselves or for a loved one, because what it means is that the care and safety needs that we have can no longer be met in our homes, and aging in place with even supports is not able to be continued. And so when we go into long-term care, or a family member goes into long-term care, we enter a whole new world with a new vocabulary, whole new terms, whole new people. And to sum it up, it's the loss of the familiar. I got involved in long-term care when my mother's needs of being safe in her home and care in her home, despite our best efforts to keep her there independently, became impossible. And so we had to go through the whole process. And I'm speaking from the perspective of long-term care in Ontario, and go through the moving of her into long-term care, that whole new world, a whole new vocabulary, whole new people, and that loss of a familiar routine. I was looking for a date of publication, and you know how tiny those dates and time the print is when you're looking for that. And as I was leafing through, on one page there was a quote all by itself. It said the author was unknown, but this is what it said: "There are things that we don't want to happen, but have to accept. Things that we don't want to know, but have to learn. And people we don't want to live without, but have to let go." That was true for me some years ago when my mother went into long-term care. But it is equally applicable today, I think, when we look at the devastation that's happened and the floodlight that there has been on long-term care because of COVID. So when we look at the 2 questions, what's new in long-term care, one of the things that I'm aware of, because in Ontario, there's also a group called an organization, and it's funded by the government, Behavioral Supports Ontario. And from my involvement with that organization, I'm so aware of what has happened across the province in homes in the COVID era that really is representative of creativity and innovation. But the other thing that seems to happen when we look at long-term care is how things are glued to politics. And when I started to think about what I was going to be talking to you about, I had all of these things like my ducks all in a row. But in the last 2 days, it's almost like every day and sometimes every hour, there's a change. In Ontario, as many people are aware, yesterday, the Auditor General of Ontario released a report, and it's being termed a scathing report about how long-term cares in homes in Ontario were not prepared for the onslaught. We also have a sick leave bill that has been going through our legislature, and then also there are federal as well as provincial pieces involved in this. and the regulations around what has happened with PSWs being able to work in more than one home. One of the original things was that they couldn't, because PSWs have to, to survive and the jobs that they can get, work in more than one home. One of the things, and I want to speak to you from the perspective of the University Women's Club North York and our long-term care working group, because that is very new. A year ago at this time, I had not been part of that group. We were not even formed, I don't think. And now here we are a whole year later. And one of the things that we have become aware of is what we can do in terms of influencing change in our province as well as across Canada. And so one of the things that we are so aware of in long-term care is the policy around that that's set by the ministry and the government, more particularly the government, the people that deliver the care, the people that receive the care, and then the people that observe it. And so in Ontario, under each of those things, there are organizations. For the people that are delivering the care, there are two long-term care associations, the Ontario Association of Long-Term Care, as well as Advantage Ontario. For residents, there's the Ontario Association of Residents Councils. And for families, there's Family Councils Ontario. And all of those groups meet under the umbrella of any ministry group, Behavior Supports Ontario, all of those things, the steering committee and various collaboratives and liaison groups. And the other part of it is we were able as a club to have each of those people, the CEO of one of the associations met with us, the executive director for the Ontario Association of Residents Councils and a resident met with us, and the executive director of Family Councils Ontario. And one of the things that we became so aware of is the fact that Ontario's long-term care system is really very complex. It's challenging and concerning. And what we wanted to do with each of those groups as a University Women's Club is to say to them, would you please tell us what you see as issues, what you see as what we can do to understand those issues and to support you, and what do you suggest that we do? Their suggestion was that we work with sending letters to our MPPs, our members of provincial parliament, which indeed we have done. We are also aware, because of those connections, of things that have happened. Because of COVID in Ontario, the government commissioned a long-term care. It's called Ontario's Long-Term Care COVID-19 Commission. And that report of those commissioners is due tomorrow. One of the things that I'm so aware of because of that is who has the power in long-term care, who has the influence, and then how do we as University Women's Club members fit into all of that? So one of the things that we are so aware of, and from the documents, because the commission at the beginning did a very unusual thing shortly into its tenure of what was happening, is that they had a report that they sent out. And the first thing was that they said, okay, from what we've seen, we are now going to say that there has to be 4 hours of care per resident. And one of the things that we became very aware of in terms of who has the power, the government had the power to set up the commission, who has the influence. And from the documents that were released, we are aware of all of those associations, the long-term care associations, residents councils associations, and family council had direct input. They've also had direct connections and speaking with the Minister of Long-Term Care, which in Ontario is a very new ministry. It was broken off from the Ministry of Health, and it has its own minister. And they have been able to meet directly, and they've had input.
You have about 1 minute, Phyllis.
So what we are aware of is that the complications and the complexity is in terms of funding and the support that's needed in terms of staffing, and then this whole new vocabulary. But let me just look quickly at the challenges. We have the challenges of staffing. From the connections we're aware of in our long-term care homes and in the organizations, that the staff are feeling shamed and blamed and shamed. And one of the things that we need now to do as we move forward, and there are direct initiatives from the government where we look at the recovery. So we need to look at the recovery that we have in terms of what the effect of it has been on our physical, social, emotional, and particularly with those who work and the challenges of delivering to residents who are older, sicker, frailer. The majority of them are really looking at some form of dementia. And then how can we support those who are family members who have gone through excruciating losses, the inability to be with their loved one, as well as the resident that's a member of the behavior support's lived experience, where for one whole year, she has not been able to see anyone in her home without a mask. She has not been able to look at that face. So how do we have influence? We have the influence, and the power that we have is at the ballot box. So the connections that we have with our MPPs, the ones who are elected federally, the ones who are candidates provincially, that we let them know the kinds of concerns we have, look at their policy, and then finally exercise the power that we have at the ballot box. And so I'll pass it on to the next speaker.
Okay, and that next speaker is going to be Mary Connell.
Hello. Thank you very much for having me here this evening. I'm so thrilled to talk about this. This is one of my favorite topics. So I'm going to try and stay within the, the time period. Okay, let me see.
You should be able to share anything you need now, Mary, but just let me know if it doesn't work.
Okay, I think it'll probably work. Okay. So I just have a couple of slides because I think it's very difficult to talk about person-centered care or emotional well-being without actually seeing some of it. And certainly to be in the home itself and to feel it is a completely different thing. And if you ever get the opportunity, I would encourage people to do it. So I'm going to talk about what I'm principally concerned about, which is emotional well-being for people who live in long-term care. The Region of Peel has adopted the butterfly model. Now that's the model that worked for us, but as Pat has indicated, there are many different models you could use. This is the one that we found matched most consistently with our beliefs and what we wanted for people in our homes and represented our families. And I'm going to talk a little bit about what's happening in long-term care now. I'm going to tell you a story because I'm also Irish and I have kissed the Blarney Stone and I like to tell a little bit of a story. So this is my friend, Michaela. Unfortunately, Michaela is no longer with us. She lived to be a ripe old age of 99. And, you know, you've heard people say every family has one. Well, she was that one in our family. She was eccentric and out there and joyous. I did a lot of tours of the home. I did over 100 tours of the butterfly home. And if there was a man on the tour, I always had to warn them, because Michaela was particularly fond of men and she'd give them a little pinch in the rear end as they walked past, even at 97 years of age. So these young men were always kind of horrified. But so I'll tell you a story about Michaela and how focusing on her and her specific needs and wants produced a great final couple of years for her. And I truly believe that if we focus on emotional well-being and see people as individuals, that the rest will fall in place because we'll be concerned about that. So here's Michaela. She's actually giving Minister Cho a kiss here. She's out playing some mini golf with him in our backyard. So changing a life. So the story of Michaela. So when Michaela first came to our home, she found it very, very difficult to settle. She was happy during the day, but at nighttime, she was very, very unsettled. And she was up walking around and going into other people's room and seemed genuinely distressed. So what we could have done was we could have called our BSO nurse. We could have spoken to the doctor and had them medicate her so she slept through the night. But what we did was we dug a little bit into her history. So Michaela was the mother of 6 boys and just loved children and loved babies. She responded very well to the babies during the day. And it was actually one of the PSWs who thought this might be her issue. So very fortuitously, Michaela's room was right across the hallway from our nursery. And it was something she spent a lot of time in during the day. So the PSW was actually wondering, is her issue at night that she's worried about her children or her babies? So what we did was we tried something with Michaela, and I'll show you a picture of her. So before going to bed at night, we would bring Michaela into the nursery, and there she is with her baby. And everybody in a butterfly home who that is their leaning, that they like babies, get one. There's some people that doesn't work for them at all, and we don't try that with them. So Michaela has her baby, and what we would do in the evenings was we would bring her in. She would feed the baby, bath the baby, and sing to it and rock it like she's doing now, and then put that baby to bed, and then she would go to bed. And as soon as we started to do that, she slept through the night. So we knew what it was that she was just concerned about her children. And she used to say during the day, where are my sons? Where are my sons? So we knew that she did have that worry. But this shows you the degree to which in person-centered care, you can focus on somebody's emotional well-being. The other thing about the butterfly model is it flattens the hierarchy. So in doing this investigation of Michaela's needs, we involve the physician and the DOC and the PSWs and the RNs, and they all come to that table along with the family members, and they have equal status at the table, and we talk about solutions. And it's totally focused on the individual. Something that has really hurt me during the pandemic emotionally, because my father had Alzheimer's, he died about 18 months ago, is that it seems like seniors or people with dementia or anyone in long-term care are kind of lumped together in a group, and they don't have individual personalities or needs or likes, and so this is something that this model or any emotional model of care does, is it makes it about the human being. So something that traditionally in long-term care would have involved, giving Michaela a diagnosis about being disruptive and going into other people's rooms, and we would have over-medicated her, and then she wouldn't have been able to react during the day. This was a non-pharmacological approach, and it solved the problem. Now, does that problem work or solved every time by non-pharmacological approaches? No. Obviously medication is sometimes appropriate. In this particular home, at the beginning of the butterfly model, we had an antipsychotic rate of 42%, and after implementation, we went down to 8%. So we really focused on the human beings that lived there and solved their problems. So what's happening in long-term care right now? So I guess that depends who you ask. If you ask somebody who's working in a home where they do person-focused care, and truly person-focused care, a lot of people use that, and it's not, that's not how they're applying it, or really focused on emotional well-being, then I would say this is what's happening in long-term care right now. And actually, I think people who are in a butterfly home or the Eden method, greenhouse, are kind of straddling 2 worlds. So we're straddling what's happening now, but I really, really hope that this focus on people's emotional well-being first and foremost before everything else is how things are going to go in the future. Because if you see this person as a human being with rights and needs and a past and something to contribute, then you'll care about what care they get. You'll care about the Ipac practices that keep them safe. There is a way to accomplish all of these things around safety and risk and still meet the needs of the human being that's there in the home. So as I said, what's the future of long-term care? Well, I hope it looks like this. I hope certainly for people with dementia, and I should say that people always associate the butterfly model with dementia, but in long-term, this thought about loving and caring for people and treating them as individuals, that could work in any care area, whether it's labor and delivery, emergency department, ICU, or in the rest of long-term care where people don't have dementia. But you can see how non-institutional that particular setting looks and how lovely it is for people that work there. That's just the setting, of course. It's the training of staff that's most important. So I'm hoping this is what the future is. So a big thank you to you again for having me. Here's another lovely friend of mine, Emmeline, who enjoys the baby. Something very interesting about Emmeline, I'm sorry, I do tell a lot of stories, is that she is in the advanced stages of dementia, but she has never lost her speech or her ability to verbalize because she was an opera singer and she sings all of her words. And she will only talk to staff if they sing back. So it's funny to go into the home, anybody who speaks to Emmeline during the day has to sing. So whether you're a good singer or not, you have to do this. And it shows you the degree to which we'll go, and I'm a horrible singer and I talk to her, to get people what it is they need. So I've just put my contact information up there for anybody who wants it. But that's it. Uh-oh, I hope oh, stop sharing. I better push that button. There. Thanks. Thank you.
Thank you, Mary. We'll go on to Karen.
And just to let you know, questions will be fielded at the end of all the panelists' discussion. I am taking notes about questions.
Thank you for that, Heather.
Hello, everybody. Can you hear me?
Yes, we can. Thank you.
Okay, thank you. Thank you very much for asking me to take part in this. An unexpected invitation, but very welcome. And the topic is long-term care, what now, what next? And I have two nows. My first now was that, as was briefly mentioned at the outset, I was a caregiver for 14 years for my dad, principally with dementia, stroke, and crippling spinal arthritis. I didn't know what to do when I became a caregiver. I asked my family doc, what should I do? I said I wanted to keep my dad at home for as long as possible. And he very clearly explained to me the reality of home care, that when the midnight shift doesn't show up because he needed 24-hour care, that I would be the midnight shift. So I stumbled along trial by error. Ultimately, I ended up going through the whole care continuum, right from home care through to retirement, through to through to geriatric care at Sunnybrook, through to long-term care during those 14 years. I never thought about to ask who owned the home that my dad was in, when it was last inspected, what the staffing ratio is. I assumed that my father would be cared for. I quickly learned not so and had to hire private care, which fortunately my father was able to afford because I am single and self-employed. My dad died of the flu in 2000 in the care home, which was understaffed, although the staff did their very best. I was led to believe the home provided palliative care. It didn't, and so it was my dad and I alone at the end of his life. Some of the lessons I learned in this now was that I knew nothing about aging. I knew nothing about being a caregiver. I knew nothing about long-term care. I accepted the status quo because my dad could afford the extra care that he needed. And what I saw was that all Canadians around me were accepting the status quo because they had no choice. I realized then that governments don't take any responsibility for educating citizens about long-term care or the provincial healthcare systems. If we need to know something, we have to dig and dig and dig. And if we're lucky, we might find something. Today, I'm an independent specialist in aging and long-term care planning. I try to educate Canadians about what lies ahead as they age because nobody else is doing it, at least as far as I know. My second now. First, money and promises are flying around and have been since the beginning of the pandemic, but Canadians are still in the dark pre-COVID about long-term care. How does it really work? How do I access it? What does it cost? How long do I wait? Did you know that in Ontario, on April the 1st, we no longer have our local health integration network structure? That seemingly overnight, it has been changed to a new organization, the Home and Community Care Support Services. And what is an OHT in Ontario? Ontarians don't know. And again, when they try and find out, they find a mess of incomplete, incomprehensible government information. Point number 2, I have listened to and talked to many wonderful people who have fabulous ideas about how to fix long-term care. And I know that they have traveled to countries around the world for many years to look at systems that are far superior to ours. And it troubles me that we get pilot projects going, we get smaller ones like Mary's going, which are clearly wonderful, but somehow they don't get off the ground the way they need to get off the ground. Another point for the now, I think the budget was a kick in the face for long-term care. Long-term care got $3 billion over 5 years, and childcare gets $30 billion over 5 years. We shouldn't forget that as many women, and let's face it, overwhelmingly women, care for aging parents and in-laws as they do for children. In our aging society, support for caregivers of elders should matter. So when you commit $30 billion over 5 years to ensuring Canadians have affordable childcare and $0 to ensure that caregivers have affordable elder care, something is very wrong with this picture. The federal government made a strategic decision that it will get more political bang for the political and the economic buck by investing in childcare than spending more on the seemingly bottomless pit of elder care. Ageism at its very best. What next? Every day things get worse, as was just said. Every day things change. And when you think they couldn't possibly get worse, the next day they are worse. When and where will it end? We know what needs to be done. What we don't know is who actually is going to do it. A few of my thoughts. Reopening the Canada Health Act, in my opinion, will never happen. Very early on, Trudeau made it clear that he wasn't interested in doing this. And the other thing that I find so deplorable is the selfishness of the provinces. All they want, the premiers want, is the money and more of it with no accountability and no respect for their aging citizens. National standards. It looks like we have provincial groups popping up, certainly in Ontario. We need true national standards with accountability, not provincial standards, which the premiers can control and bend to their financial benefit. Does Trudeau have the guts to stand up to the province on national standards? I don't know. And if he doesn't, he won't get my vote. Can long-term care be fixed? It depends on what your definition of fixed means. If you mean more beds for the 37,000 plus waiting, yes, to a point. For it is busily awarding more beds to companies of all kinds to build more high-rise institutions. If fixed means listening to what seniors want to age in place, many of them, I honestly don't know. Allowing seniors choice in where to live out their lives with dignity takes experienced planners, money, but mostly it seems it takes political will. We have seen zero political will for 25 years. Over the years, or during the time when I was involved with my father and since, there have been countless scandals in long-term care, which are reported by the press. There's an uproar, somebody was murdered, somebody was physically abused or sexually abused. The uproar dies and people go back to their normal lives. I wrote an article on this issue a year ago and said that what many are also saying or have said, that if COVID does not provoke serious systemic change, nothing will. The saving grace I see now is the public uproar about long-term care, which has not gone away because our older people are still dying. If anything, it will be the anger and the grief of Canadians that may finally force change. I think that long-term care, and this is my humble opinion, is being run by politicians and private money. Both groups are benefiting so much financially that this government in Ontario will move to its own agenda, not the will of the people. Maybe a change in government will move things forward, but it has not in the past. Thank you.
Thank you. We'd like to move now to asking a couple of questions from ourselves, and then moving to taking questions from the chat. And I'm going to suggest that we'll ask the question, any panelist who wishes to have a comment on it would be allowed to comment briefly. And I think I'd like to start with the recent proposal of a private member's bill in Alberta, which is meant to protect long-term care facilities from civil suits on negligence. And we're wondering about the, I'm going to say this word wrong, constitutionality, help. How constitutional would this law be? And what would the impacts be on long-term care residents and their families? Does anyone wish to start? Perhaps not a good question.
I have to apologize. I missed it because I was trying, people were freezing on me and I was trying to get the.
Okay. I was just mentioning the Alberta private members bill that was proposed to protect facilities from civil suits on negligence, and whether or not that is constitutionally possible, and what the impact would be on long-term care residents and their families.
We have the same kind of legislation in Ontario, just recently passed as well, to protect them from lawsuits. I think this is related to what Karen was saying. Is it constitutional? I don't know. We'll have to wait and hear what the court says. But I actually don't think suing them is the solution. We have to go much more in the route, I think, that Karen is talking about, which is basically we need to get rid of the profit and care. I think that's one of the first steps we have to take, because if we look at where the deaths, where the low supplies of PPE, where whatever we're measuring, staffing levels, there's a clear pattern in terms of the problem with for-profits, and they're really what's being shielded in this by this kind of legislation.
Phyllis, I'd invite you to speak to your note in the chat.
Sorry, that mute button just eluded me. One of the things that's just been recently announced, and it's from the National Institute on Aging, and it says NIA Dr. Samir Sinha is to chair the HSO, that's Health Standards Organization, as well as the Standards Council of Ontario and the Canadian Standards Association. They're collaborating to develop standards that will be shaped by the needs of residents, families, and care in Canada's long-term workforce. And one of the things that is happening is that there is the capability when it gets rolling, it's just recently announced, is for input. So I'm aware that there are long-term care homes who are running surveys about information. I haven't been able to see the exact survey, but they are going to be able to give input about the national standards. one of the things, and it's sort of been alluded to in the chats that we've had so far, is that long-term care is provincial, and but there is this whole look at what's expected from national things, and the premier's saying, just give us the money, don't tell us what to do. But this is, I think, a very helpful and hopeful step forward. Dr. Sinha is a very well-respected geriatrician. He also has great humanity, and I was just so pleased to see that when we look at standards across the country, that this initiative is just underway.
Karen, would you
If
like
I
to?
can-
Oh, sorry. Go ahead.
Can I say something on this? It is following in the accreditation. It's an accreditation project, and all of the homes in Quebec were accredited by this outfit before. I'm really hoping, if it does go forward, that it is something beyond the accreditation process that is there right now. Virtually all of the for-profit homes in Canada have been accredited by this same outfit. I'm hoping that I think that we should pay attention to any of these processes. I think we should have input, but I think it's another way to keep consistent with what Karen was saying. It's another way for the federal government not to do it, to hand it over to some other organization and avoid the political project of actually having standards in place that can be enforced, because this accreditation outfit doesn't have enforcement activities of any real sense.
What I can say, I wasn't aware of the accreditation part, but it's sure been an attention grabber, and the stakeholders in Ontario seem to be very aware of that. And of course, the big thing in the announcement was the fact that Dr. Sinha is going to be chairing it.
Well, I think we should take any opportunity we can to have influence, but I'm not holding up. I'm a little concerned about this as the process.
Yeah, I've heard comments made about the fact that we already have a process for the accreditation of acute care hospitals. That's not the same thing. And that's not the route, I don't believe, to go down. I'm wondering, Karen, if you have anything you want to add.
I agree with Pat. I think that, to me, it's not really clear. There's several arms of this project. I mean, having Dr. Sinha involved is a clear winner, because he's very highly thought of. He's the ever-ready bunny popping up everywhere, actually. The poor man must be exhausted. But I still worry that somehow the provinces are going to take over the process, and that they will say, we can establish our own standards, don't worry about it, leave us alone. And that's the way that it's going to go.
Thank you. Just to move to a slightly different topic within the topic, according to the Cfuw BC survey, 90% of our seniors would prefer to age at home. And funding allocations for the government are 90% towards long-term care and 10% towards aging in place. How would you see that we could mitigate this inconsistency or inequality?
Well, from what I understand, it's the province, when they receive the money, it's they who allocate it to this pocket or that pocket, or this area or that area. And clearly the money in Ontario is going to long-term care facilities, and it's not going into home care. And again, the province has the power to do this because they don't have to account to anybody. And we just get taken for a ride, and so far have had to live with the decision of where the money goes. And I'm hoping that, again, with public pressure, with the grief that we see in people, that this will be powerful enough to push for more home care, and if there has to be more institutional care, and which there will be. We can never do without beds, but that hopefully they will be in smaller community type settings, the type of place that Mary has, and that people will be able to live out their lives in an environment which suits them and which helps them thrive.
Could I just say, Karen, you were saying yourself that you reached the point where with all the support you could put into the home, there just wasn't enough and your father couldn't be maintained there. So there is a limit to what people can, to what the home care can do. And I think the other is there's such a shortage of PSWs. So even if one is willing to pay for them themselves beyond what they're funded for, they're just not out there, just as they're not in the home. So they're quitting over conditions of work and low status and poor pay.
Well, that's a very good point. Dr. Sinha admitted quite bluntly in an article that how did he say it? The best way, the most successful aging is based on having family support and money. Because 2 years ago, money could buy you the home care that you wanted. But now, because we don't have the people, we don't have the caregivers, the PSWs, maybe it's not going to matter how much money you have because there just simply aren't going to be enough people to go around. Things will come back around again where money will play an important role. And if you have it, you can rise to the top. And if you don't, then you're more at the mercy of the system and what it will offer you or give you.
I just wanted to add that I have concerns about this. And I think Pat and I've spoken about this before, that I totally think if we could have kept my father at home, we would absolutely have done it. So when people talk about home care, I don't want people to think that if someone delivers your groceries and shovels your path, that's all you're going to need. I have to be honest, I don't trust that there'll be the robust system in place that will support people. My mother, 2 weeks before my father was hospitalized in crisis, was offered 15 minutes of care. So I think, again, that'll be a woman's issue again. Who will be looking after them in the home besides doing the online learning with the kids and all the other stuff? I think it'll be women. So we have to be careful that if we want this, and I think we do, we need to make sure that it's a robust system.
And can I say something on this? It's we do. It's not surprising that people say, "Yes, I want to stay in my own home." That is if you have a home, first of all, yeah. And we have to remember that homes are often places of abuse as well. As we have become more visible during COVID. But when we study long-term care homes and we go into them over a week, we take a team of 12 to 14. We're there from 7 in the morning till after midnight. And we talk to the residents council, we talk to everybody who's there. And a resident council was very eloquent very recently when I was asking them if there's anything better about being here than being at home. And they were unanimous. They said yes. And 3 of the reasons they gave were, first of all, I feel safe, which might seem a little weird in COVID, but they feel safe in the sense that one example that we're given was one woman said, I had a stroke. I can't remember to take my insulin. If I don't have my insulin, I'm going to die. Here they make sure I have my insulin. The second reason they gave was that they have company. If I was at home, I'd be all alone. Here, there are always people around. The third thing they said was that their activities, we hear people say all the time that they just stick us in front of the television set, but they said, if I was at home, it's the only thing I do. The other thing I would say about surveys that ask people if they would rather be in their own home, I'm not surprised given what we've heard about long-term care in the media, especially recently, that you would think that there's no way I want to go into one of those places. But we've been into some very good long-term care home, including the one Mary's talking about. And it can work and it can be a good place. There are bad places out there, that's absolutely true, but it's not the majority. And the majority of homes didn't have COVID deaths. We have to remember that when we're talking about this. And there can be good things about congregate care.
Yeah.
If we make it possible.
So I have some questions
Yes.
from the chat.
Yeah.
Mary, from your talk, there were two questions that sprang up. What is the IPAC model? And people want to know more about what the butterfly model is.
Oh, so Ipac is just, I'm sorry, I'm an old public health nurse and I throw around terms and I shouldn't, but
It's
that's
okay.
just the infection control standards that they're currently have in place right now under COVID-19, or they're standards that they have in the hospitals or in all long-term care facilities all the time to prevent flu and infection. So wearing PPE, washing your hands, social distancing, these are all Ipac or good public health measures. So I apologize for using that lingo.
That's okay. And they wanted to know more about the butterfly model. Why do you call it the butterfly model, and what's more about it?
So the butterfly model is based on a relationship model. So it's about creating opportunities for engagement or relationship between two individuals or an individual in a group. So in the case of the butterfly model or the Eden model or greenhouse, the relationship is produced between people who live in the home and people who work in the home. And end result, it is mutually beneficial to both. So for example, from a staff perspective, we saw incidental sick time of staff reduced by 75% because they were so happy to work there. And then there's a number of outcome measures that show that it's beneficial to the human beings who live there as well. So that is the drive-through definition of what the butterfly model is.
Okay. Next question. Would the, Karen, this is a question that came from you, or came from your talk. Would the problem be fixed with more beds?
We have a waiting list of over 38,000 people in Ontario, and there's a huge waiting list across Canada for a bed in long-term care. Many of those people do need a bed. They may be suffering from dementia, which has become very problematic for families to keep managing. But there are also about 1 in 7 or 8 people on that list who are on the list because they don't get the subsidized home care that they need to stay in their own home. So there's been an argument about why don't we get rid of all long-term care beds and just let people either remain in their own homes, remain in their own communities. But I think that it's been also said that we cannot get rid completely of beds in long-term care. What we can get rid of is the institutional approach that we take to the way that we fund these beds, the way that we design the homes that these beds are in. And then it also involves the for-profit side of it. People have said we need to get rid of for-profit. They don't belong in healthcare. And it would be great if we could get rid of them, but also we need the beds. And so again, it comes to accountability, that they need to be held accountable for the money that they have been given for renovation, the money that they continue to be given. And I quite frankly don't think that the information that we get from these homes is complete about where the money is spent. And because clearly they're making money because it's going to shareholders in huge amounts. And also it was just revealed that it was the CEO of, which one of them? I can't remember. Maybe it was Chartwell, got a pretty hefty bonus, as well as shareholders getting a very good return on their investment. So the money's coming from somewhere, and I don't think we're really very clear about how that money is being funneled.
Okay. Thank you. This is a question for anybody. Maybe Pat and Phyllis have the answer to this. Do you know if there's a policy in other provinces about till death do you part legislation, where it allows access to long-term care for couples who want to be together? Is there such a legislation in Ontario and or other provinces? I believe someone commented that it might be stalled in Ontario, but that if there's a policy like that in other provinces. It's called Till Death Do You Part legislation.
What I'm aware of is that in the Long-Term Care Act, I believe it is, they talk about reunification. The problem really is in finding a room where the husband and wife can be accommodated. The home that my mother was in, there was a husband and wife there, but the husband was on one floor and the wife was on another, and they had different care needs. So I know that it's been a topic of discussion in Ontario for a very, very long time, but obviously in practice, it's still a big problem, because the other part is that the availability of rooms, there tend to be a larger proportion of women than men, and that right away creates some problems. And then putting couples together, and it may well be that the care needs of one is different from the other, and so it's quite problematic. But I'm not aware of a death to you part bill. I just know about the legislation in Ontario.
Okay. Anybody else want to speak to that?
Can I just mention something else? Just jump in about the private versus public. So I agree with what Pat's saying. I know that there are some tremendously horrible actors in the private, and of course I come from public on municipal homes. But there are also some, though I think those are the bigger companies. There are also some homes like places like Primacare, who are doing the butterfly model. So there are some who are really doing the right thing, but I do agree there are these big ones that make profits, but I don't want to wipe them all with the same brush. There are some very lovely private ones. I just want to say that.
No, you're absolutely right, Mary, that there are some wonderful private homes, smaller ones. But not all not-for-profit municipals are painted or perfect either. There's been some pretty bad outbreaks in those homes as well. So I guess the point is that it doesn't matter whether you're profit or not for profit. There's bad actors in both groups, and there's some wonderful performers as well.
Yeah.
We are talking about patterns, though, and I agree with Mary. There's private and private. The big change over the last 20 years, especially in Ontario, where we have the highest proportion of for-profit homes at 57 or 58%, depends on how you're counting, that we've had a long tradition of private homes, but they've tended to be small, family-owned homes that are quite different from the corporate-owned ones. And it's the growth of the corporate-owned ones that has been mainly happening, and that's the examples that for instance, that Karen was talking about, and that company just had a motion to consider paying a living wage to the staff as they were giving bonuses to the executives, and they turned down the living wage. Right. So yes, of course it's a pattern. We're always talking about patterns, right? But there's a clear pattern in terms of what's been happening during COVID especially. But there's a pattern of lower staffing levels, of more transfers to hospitals and more bed ulcers. But we're always talking about patterns, whether we're talking about patterns on who gets blood clots or not. Right?
I have a question here from Odette, who's asking, isn't it true that only 10% of all seniors enter long-term care and have far greater acuity in terms of medical needs than a decade ago? My understanding is that most people who go to long-term care could not stay at home with home care due to their medical needs, also dementia, that puts them or others at risk. Could someone speak to this? She's kind of answered her own question. Does anybody want to say anything more about that?
Well, I think it's true. It can't be denied that people in long-term care are older and frailer and sicker than they were. Certainly when my dad was there, there were people back then, there were people actually moving around and being mobile and you know, just sort of living a normal life. And towards the end of his time there, and then as I have gone back into homes subsequently, the number of people in wheelchairs has just exploded. And the number of people who have dementia and who are screaming out has increased. And so from my experience now, people in long-term care are sicker. But you know what? We could keep people at home longer if we gave them the proper care and support right at the very beginning of their illness. And it just seems that we wait and we wait and we wait until things get so bad that someone with dementia and the family are just done, and the family can't take it, and the person ends up in long-term care. We're not proactive in our healthcare system. We're reactive. And I did read about Denmark and how they try and re-enable people who are living at home to keep them healthier and give them the therapies that will allow them to remain more functional, both cognitively and physically, so that they don't move to long-term care until they absolutely either can't, the system can't afford to keep them at home anymore, or they just need so much care that they move into a smaller home.
But they still have long-term care facilities in Denmark, which we tend to forget to some extent. But also, if we're going to talk about keeping people at home, we have to talk about bigger issues like cleaning the sidewalks, making walkable cities where you can get the services you need within walking distance. That is, we need to think bigger if we're going to think about long-term care. And there is no way that we can publicly pay for 24-hour care for somebody, each individual in their home. It just doesn't even make sense if that was possible. But there are ways that we can certainly contribute to making sure people don't break their hip falling on slippery sidewalks and end up in these kinds of conditions, it seems to me. And in terms of the change, I first started studying long-term care in the 1990s. Actually, it was about pay equity, but that was the first time I actually spent time in a long-term care home. And at that time, they weren't allowed to have any medical equipment. You couldn't have anything like oxygen or any of the other things that we see there now. I mean, it's completely different in terms of the kinds of complex needs that people in long-term care have now.
Another question. Why is long-term care not funded the way hospitals are? Both are healthcare. Is that a naive question? People don't know. People are asking this question and they want to know why it was left out of the Canada Health Act.
Well, extended health services are in the introduction to the Canada Health Act, but they aren't anywhere else in the Canada Health Act because it's focused on medical. But when when we first got hospital insurance and then medical insurance that get brought together in '84 in the Canada Health Act, the concern was about people getting medical care. But remember, we had a lot more people cared for in hospitals. We had chronic care hospitals, we had psychiatric hospitals, we had rehab hospitals, and an awful lot of the people who are now in long-term care were being looked after in those places. Now we have closed those and we've more narrowly defined what's a hospital and thus covered by the Canada Health Act, which is one of the things that's happened. But I mean, it isn't that, as we often think in terms of, you know, back in the past, all of the older people were looked after at home and cared for well when they were there. People weren't living as long.
Mhm.
They certainly weren't living with these kinds of complex care needs.
Right. Good point. In Ontario, and I hate to be Ontario-centric again, I'm sorry, Kathy, our nonprofit homes offered the same amount of money as profit homes when they are being managed by, when the government is contracting with them. Are they getting the same amount of money to manage long-term care?
Yes, they are. One of the complexities is how homes are funded. And this is where a whole new vocabulary. The Long-Term Care Act for Ontario says, in terms of funding, funding is based on the assessed needs of the residents. And so it's a very complex system. The language is CMI based on RI MDS. And what that really is, every home is given a case mix index, and that's based on the assessment and a number that's given called the case mix index. That's based on this system of assessing. It's an instrument that assesses individual residents' needs, and it's called a minimum data set, and it's an ongoing thing. And it's called RI, and in the homes there are coordinators for that. And one of the things we heard from one of the long-term care associations is that it sometimes, and I'm not quite sure how they do it, I think I could guess, but they talk about gaming the system. And what happens is, based on the number that they get in a home, regardless if it's for care, profit or nonprofit or municipal, that number is given in 4 envelopes. So there's nursing and personal care, raw food, program and support services, and then there's another one that's called other accommodation. The other accommodation is the one that funds wages, equipment, supplies for dietary, laundry and housekeeping furnishings, maintenance, operating and administrative costs. And then there's this little sentence, and this is where for-profit comes in. It says, operators may retain as a portion of the OA, other accommodation envelope, as income. And then all of this is very carefully audited. And if the envelope hasn't been properly looked at, the home will have to pay for it. But if there's anything left over, which is unheard of, I would think, that needs to go back to the government. So this is one of the complications. And so in the letter that the North York Long-Term Care Working Group sent under the signature of our president to the MPPs is we were recommending, from what we have learned from our connections, that the whole funding system be looked at, because funding is so connected to staffing. So whether it was for profit, a municipal home, a nonprofit home, every March, all of the things that you hear is from the administrator of a home, we've got our number now, and this is how it's affecting our staffing. And so it's just an ongoing program. And so that's why we're recommending that it be looked at.
Thanks, Phyllis.
Mhm.
Anybody else want to comment on that question? That's a pretty thorough answer, though.
Oh, I should just add that the reason that this also came is the ministry has issued papers. The one that deals with the funding was issued because it goes into the explanation, all of those envelopes that I just talked to you about, to the commission. And so that was part of their response, and they detail it. But as you can see, it's a very complex thing. It's very mind-boggling, but it's the source of how funding happens in a long-term care home.
Okay.
It is the case that municipalities in Ontario may give extra money to their long-term care homes. So for instance, the city of Toronto gives more money and has just raised their staffing levels as a result, as a direct result of that. or and the nonprofits might do charitable organizations in a way that people aren't prepared to do to a for-profit, to a corporate home.
And from when I was more directly involved than I am now, one of the things that I heard, because I got involved via family councils, was that the two associations, the for-profit and the nonprofit, are sort of rival with each other because of those kinds of things, the tax breaks that I've heard about and the things that Pat has just mentioned.
Okay, so maybe as an adjunct to that question, do faith-based long-term care centers with their own boards operate any better than other kinds of long-term care facilities? And operate better is in quotation marks. Are there any?
I'm sure I'm annoying.
No, you're not.
I'm annoying turning my video on and off because my things on my videos on internet's unstable. In terms of to go back to what I was saying about patterns, if you look at, for instance, staffing levels, the highest staffing levels are in government owned. The next highest are in not-for-profits that are the charitable ones you're talking about, and then the lowest are in the for-profits. So there's the continuum is in general better quality in the government, and that the not-for-profits are in between, and those are the ones that are owned either by religious organizations or the Italian community or the Ukrainian community or whatever. And so, but we're back to patterns again, right? Not
Exactly.
Universal.
Okay. Regarding personal service workers, is there any push for better education and training for them anywhere that is notable across the country? Go ahead, Pat.
I hate to do, well, the Ontario government has just announced a whole lot of money for training and regulation of what in this province we call personal support workers. Quebec did that early on in COVID, prepared 10,000 more people to do what they call orderlies, which are equivalent to the PSWs here. And so there is a movement, but it is true in Canada for the labor force in general. We don't have national standards for healthcare workers. And one of the issues, for instance, that just came up with the federal government saying that they would bring Newfoundland doctors to Ontario was the question of practicing in Ontario when they're. We need not only national standards, we need a national healthcare labor force strategy.
Are there not career standards for things like respiratory therapists and physiotherapists and personal service workers? Do they not have to meet a career standard? Well, the regulated workers are ones, but those are provincial regulations, right? Provincial and territorial regulations. But they like the registered nurses or therapists or whatever, we call them registered in part because they do go through a registration project, that there are standards that everybody within that jurisdiction has to meet. That's not the case in the most part for those people that in Ontario we call PSWs. They're called care aides, and other provinces are called. Okay, okay. We're getting into the political notions now. For the last half hour, there are a number of questions about politics. So how do we get the personal care models adopted? I'm just going to reel off a couple of questions. How do we get how do we go forward politically? And what is your advice for an advocacy group like CFUW in terms of making a difference? I would invite everybody to comment on those questions. Start anywhere.
I would
Care-
say about the adoption of personal care models. I wish I knew the answer to that. I've been working on it tirelessly for the last 5 years, and it's moving slowly. There are 11, 12 homes in the province right now that have adopted some kind of a model, but I would hope that there would have been more by now. So if anybody else has the answer to that, how to do it, I would be very interested to hear it.
Come on, Mary. I thought you had a national tidal wave motion kind of a thing.
I wish.
Okay. Anybody else have an idea for advocacy to make a sweeping tsunami happen here?
Well, I think that it was earlier said that CFUW was advised to write to their MPPs, which is a very good thing to do, and also to use the press, to write letters to the editor, and to not stop, because there are some journalists who work for The Sun, for The Star, and of course Andre Picard with The Globe, who are heavily involved in trying to explain to people what's going on. And they are more than brutally frank in many cases. And so I think that we need to support these journalists and continue to let the editors of papers know how we feel. And obviously, every time that I get something in my mailbox that asks me to sign a petition, I absolutely do it. And then I try and throw it up on Facebook so that other people can see it. And I encourage response to that particular petition.
I think that in spite of the fact that I am very bad at this, that social media is really important. And it's interesting. I don't know if you know that the health coalitions and the Council of Canadians and a number of other organizations did a massive cross-Canada effort. When was it? Tuesday, I guess, on long-term care, and they were doing it on Facebook. And the small part that I was involved in, there weren't many people at all watching it. But then it rippled on, and it has been picked up big time. I don't just mean the panel I was on. The whole thing has been picked up big time. So you see how it can be spread that way. And I think that we need to do more of that. And to go back to what you said, Karen, earlier about people not knowing about long-term care, if you think about what happened in the media at the beginning of the COVID, the number of people who were phoning me to say things like, are there really 4 bedrooms in long-term care? The lack of knowledge or familiarity with the sector was huge. And that's why when I talked about access, I said access is also about information. And when the Auditor General report came out in Ontario yesterday, one of the things she talked about was the bad communications. But what we need to do is be better at the communications.
Okay. Any other comments on that in terms of advocacy and how we could be better at it?
Something that we've had some success with is looking at members of provincial parliament and finding people who either are associated with the Alzheimer's Society or CARP and getting them to petition their actual member of provincial parliament and getting a meeting with them. Now, I ask all the time and I always get turned down, but I find somebody who's one of their constituents and go with them and do a presentation and have kind of a call for action and an ask of that politician. So that has helped us strategically. We've got into a number. We actually have hopefully a presentation coming up with the caucus based on meeting with the parliamentary assistant to Christine Elliott. So fingers crossed that happens. But it was one of her constituents that got us in there.
Okay, good to know. Good to know. Catherine Wilkinson, I know you're on the line here somewhere. Did you want to speak to anything that's happened tonight? Are you still with us?
I am still with you, and it's bringing back lots of memories because I had to find respite care for my mother in Britain, and went to look at a number of homes and the variation in standards. And what's striking me, and I did put a question in which Heather ignored.
No, I didn't. I didn't mean to ignore it, Catherine. And may I just say, Catherine Wilkinson is the president of CFUW, for those who may not know.
So my question was, is size a big part of this, so that the bigger a home becomes, the more it becomes like an institution? So that I think, we mentioned at the beginning about people complaining about food, complaining about their laundry. The fact is, if you get into a big home setting, you're going to have more of an institutional laundry, you're going to have maybe more institutional food, you're going to see more caregivers. And when we talk about national standards, should we be looking at smaller settings that are more like a home base? Even like years ago, where they used to have children's homes, but they would have a group of houses within a grounds, and I'm not advocating children's homes in any shape or form, but I'm thinking, that if you had a group of small houses that then were in a central setting where people had more of a home-like setting rather than an institution. So that's my thought. I think, I think of myself, what would I want to be? And I would not want to be in a big home with multiple people coming in and sitting in like a school dining hall. And so those are my thoughts and my question.
Anybody want to respond to that, Pat?
I think you might get 4 different answers here.
That's good. 4 different answers are good.
We had a lot of debates in our team about what constitutes home-like, as I mentioned earlier. And I know we've heard a lot recently about the Nordic model. And I spent a lot of time in Norway and in Sweden. And they have homes of various sizes, but there can be benefits and problems with both. If you're in a big city, it's very hard to create anything like a dementia village that became very well known for a while. And it's not impossible to have a big place that is small within, to have smaller units within that big place, and to make those units home-like. After all, a whole lot of people in the city of Toronto, where I live, choose to live in condos, and build big buildings, and that is their home. And you can get some advantages of size. You can, for instance, have your own doctor and your own hairdresser and your own services in a way that you can't in a quite a small place. And in fact, connecting nursing homes or long-term care homes to hospitals in small towns has been able to allow them both to survive by combining services so that you can share those services. You also have more flexibility in your labor force, and you can provide some more services. So I'm not saying big is always good, but small isn't always good either. And when we took these teams into homes over the course of the week, all of the teams were international. So it was interesting when the Swedish and Norwegian people came to Canada and saw some of our big homes. They said, I can't imagine. And the 35-person hallway is clearly not anybody's idea of a home. A long hallway that looks like a hospital, which was the model for a lot of our homes here. But at the same time, they said, we've started to think that maybe our places that are 8 or 10 are a bit too small. I've been in homes because, like families, they can get a little incestuous, right? But in Nova Scotia, for instance, in some of their Eden homes, they have smaller units in a bigger building, and you can move from one section to another during the day as well, at the same time as you have this smaller place within. So I think that there are all kinds of possibilities, and including mixing them up. So in a home we were in Sweden, there were several floors that were student residences. You know, so you mix generation and you mixed. So I don't think, as Mary said before, I don't think there's one single model, but we can learn from all of them.
Thanks, Pat.
Thank you. And yeah, and I was going to say the presentations have all been fantastic this evening. So thank you.
That's a good note on which to say thank you so much for the intriguing and lively question and answer period. And thank you again, all of you, for coming to spend this time and share your insights with us. And I'm sure everyone else like me has learned a great deal this evening and has been given a great deal of food for thought. So you're invited to stay on. We're going to just pass it over to Charlotte, who's going to just give our members some extra information that they need going forward on this issue. So Charlotte, pass to you.
Thanks so much, Sheila, and thank you to all of our panelists this evening. It's been a really great discussion, and I feel like I learned something new every single time I'm reading about long-term care. So in any case, we are still accepting signatures on our open letter to the Minister of Health and the Minister of Seniors to advocate for legislated national standards for long-term care and the public provision. So I just sent a link to that in the chat. And again, I encourage you to use the, oh, Heather's got her sign up here, to use the power of social media like Pat suggested, and to send in your photos of you holding a sign. Here we have Sheila, and we are going to be putting all of these pictures and quotes together. I believe I have a picture of Cheryl, who's on the call right now, as well. And you can send those to me at cfuwadvocacy@rogers.com. I can send all of these links in the chat. And we hope that you, again, write your MP as well, an MPP or MLA, depending on your province. We have some template letters that we included in the long-term care day of action toolkit that I just sent a link to in the chat as well. So again, we really encourage you to write your elected officials, get our asks out there. Like Karen was saying, you know, don't let up with annoying your elected officials. And yeah, so lastly, please, again, you know, please join us on May 4 at 1 to 3 p.m. Eastern time for our national town hall. I'm also going to be sending a link to register for that in the chat as well. So thank you so much for joining us. And we have a lot of action items coming up for us in the coming days. So again, you know, our 3 calls: sign our open letter, register for the national town hall, and send in your pictures if you have a sign, or make a sign. I've got mine on my pizza box here. So maybe take the weekend and dabble in some creative arts and make a nice sign. So again, you know, really pushing for attendance at that national town hall on May 4, and to write your elected officials and get this, you know, get this issue, you know, up and in their face.
So Charlotte, if I can, I'd like to just thank both you and Heather for your excellent support in putting this on. Couldn't have been done without the 2 of you, and you're perfect. You're wonderful. Five.
And so are you, Sheila. Thanks very much for hosting. And thanks again to the panelists for being such excellent presenters and encouraging us to be the fantastic advocates that I know we all can be.
Thanks so much, everyone.
Good night.
Thank you.
Have a great rest of your night.
Thank you.
Thank
And
you.
may the 4th be with us.
Thank you.
Sign the letter. Take your
We will.
pictures, pull up a poster, share something on social media. We've got plenty of ideas in the
Remember that the May 4th event is public, so invite your friends to join us.
Could we have a little more information about what will happen at it? I've been asked and I haven't been able to say to anyone what's going to happen at the May 4th event.
It's going to be the advocates that we have across Canada, their offices and what they do. So it's called an advocate's point of view. So we have Isabel McKenzie from British Columbia. We have Pamela Daw from Newfoundland, and Robert Savoy and
Graham Cotsey.
Graham Cotsey, both from New Brunswick. And so they will be presenting, and then there will be questions and answers, and hopefully a stimulating discussion.
Okay, thank you. That's helpful.
And thank you. It's Maria here from Minister Schultz's office, Minister
hi.
of Seniors. Hi there. So I wanted to thank you for the invitation for us to be here this evening and join you. I have taken quite a bit of material to bring back to the minister. So thank you to everyone that asked questions and to those who contributed their ideas and solutions. And as I say, this will go back for consideration for the minister. And we look forward to future discussions with you.
Thank you,
Thank
Maria.
you so much.
Thank
Yes.
you.
Thank you.
Looking forward to seeing you on the 4th as well, Maria. Is that right?
I am. I'm confirmed.